My name is Malcolm Rickaby. I'm President of Multiple Sclerosis Society of New Zealand and also President of Multiple Sclerosis and Parkinson Society of Canterbury. It is my great pleasure to introduce you to Professor David Miller, a fellow New Zealander, and that's very important. David is a Professor of Clinical Neurology at the Institute of Neurology, University College London, Consultant Neurologist at the National Hospital of Neurology and Neurosurgery, UCLH, London. His major clinical activities and research interests have been based on multiple sclerosis. David spends about 6 weeks each year at the New Zealand Brain Institute here in Christchurch. He was the initiator at an MRI study of multiple sclerosis here and contributes to his expertise and vision to the local and growing MS research group. As today is World MS Day, it is a real pleasure to have Professor Miller to speak to us on progress in MS research and treatment. The floor is yours, David. Thank you.
Thank you. I'd like to thank you, Malcolm, for the invitation to speak. This is World Multiple Sclerosis Day. This is something that's been happening for about 6 years now around the world, where various MS societies and the MS International Federation try and highlight this disease and what's been happening in terms of progress and what can be done to help care for people with multiple sclerosis. So it's a pleasure for me to be here. As Malcolm said, I'm a New Zealander, and I hope my head isn't in the way of these slides, but I grew up in the South Island. I went to medical school in Dunedin, and then after graduating I went to Wellington for 6 years, where I started my first 2 years of training in neurology. That was in the early 1980s. And then I went to London, where I continued training, and then I ended up eventually pursuing my career in London. But I already had an interest in multiple sclerosis before leaving Wellington. We did a survey of everyone that we could find in the city and in the environment back at that time, and we already learned quite a lot about MS through that study. I remember it very well, working with one of my mentors, Dr. Dick Hornibrook. So then we went to London, and in the last 4 years, it's been a real pleasure to have these recurring links to New Zealand by coming back to Christchurch and collaborating with Debbie Mason and Sridhar Alla and other colleagues at the New Zealand Brain Research Institute here in Christchurch. So I've seen MS in 2 countries, and there are a lot of similarities, but also some differences that one can learn about the condition from these countries. So when I first went to London, it was 1984, and in fact, almost the day that I arrived at the hospital, there was massive security. It's a little square in central London called Queen Square, and basically the place was closed off because we had a very important visitor. There he is. He looks a bit younger. Prince Charles came to open the very first MRI scanner, and it was paid for by the United Kingdom MS Society. It cost £1 million, and it was dedicated to study multiple sclerosis. And basically, MRI has proved to be very useful. It's a major tool for helping to make an early diagnosis, and it's also used to monitor new treatments, and has been playing a key part in bringing forward the new treatments that we now have for multiple sclerosis. But over the course of the 30 years, the quality of the scanning has improved a good deal. The bottom left is the old scans from the 1980s, and the bottom right is the much better quality scans one gets nowadays. Actually, behind His Royal Highness is another New Zealander called Ian MacDonald, who was running the multiple sclerosis service at that time, and he was a great mentor of mine. He died about 8 years ago. I have to say, we haven't seen His Royal Highness back since that time, but you never know, he might come one day. This is the present group that I work with in London. The Queen Square MS Centre, the National Hospital. We've been supported over many years by the UK MS Society, particularly doing imaging research, but also increasingly doing a lot of clinical trials as well. One of my colleagues here, Jeremy Chataway, is leading on a lot of big clinical trials at present. And as you can see, the weather in London is a good deal better than in Christchurch at the moment. So I'm going to talk about MS, about what's happened in terms of progress and particularly treatments, and also discuss some of the research that's taking place here in Christchurch. Just to summarise, this will be, I'm sure, very familiar to many people here, but MS is a condition that comes on usually in young adults. It affects women more than men. It can cause a large variety of symptoms, such as impairment of mobility or sensation or continence. It may affect vision, cognition, fatigue and pain. And it has a very variable course, so that after 15 or 20 years, about a half of people will have quite a significant disability, may need assistance to walk, but about a third actually can be very well with very little disability. So it's got this very variable course, and that's quite a challenge because it's hard to predict how things will turn out at the beginning of the condition. So what causes the symptoms of MS? Well, I'm trying to illustrate that in this slide, and this slide is showing a model of actual nerve cells and nerve fibres as they occur in the brain or in the spinal cord. The round grey circles are the nerve cell bodies, neurons, and connected to them are the long fibres, or the axons, the nerve fibres. And the nerve fibres are surrounded by a fatty insulating sheath, the myelin sheath, and it's just like electrical cables are insulated. They conduct better with the insulation, so the myelin sheath is important. And there's a cell, a specialised cell called the oligodendrocyte that generates the myelin, that keeps the myelin sheath healthy. So what happens in multiple sclerosis, and I'll talk about why it happens later on, is that there is damage to the myelin sheath. It disappears in patches, and also the cell, the oligodendrocyte cell, may also be damaged and die. And the result is that if the nerve fibres lose their myelin, they don't conduct signals any longer, and so there is a loss of function as a result of that. Now, the symptoms that occur depend on where the myelin is lost. So it may be lost in the brain, and these arrows are pointing to several lesions in the white matter of the brain. Then this is a myelin stain of the brain, which shows a black area when there's normal myelin. You can see the little punched out holes where the myelin has disappeared in the white matter of the brain. All these lesions may occur in the spinal cord. This is a cross-section of the spinal cord. These are post-mortems, of course, and you can see this big hole where the myelin has disappeared on one side. Or it can occur in the vision nerve, the optic nerve, and again you can see where the myelin has disappeared. Now, in some locations it won't cause any symptoms, such as some of these regions of the brain which are really silent in terms of function, but in areas like the spinal cord or the optic nerves, it's very likely to cause problems with sensation or movement in the case of the spinal cord, or with vision in the case of the optic nerve. So we don't know the precise cause of multiple sclerosis, but we do know quite a lot about the factors that increase the risk of MS and contribute in some way to it. And part of what's happening at the moment in New Zealand is a study to try and understand more about the nature of MS. And this is called a New Zealand Instant Study, which has been funded by the MS Society. And the leading investigators here tonight, Debbie Mason and Sridhar Ala. And they have been conducted a study for a 12-month period from the middle of 2013 to the middle of 2014, where they identified every new case of MS that was diagnosed throughout New Zealand. So they worked very hard, contacted all neurologists, backed it up by checking on hospital diagnosis records, and found that there were 272 new cases of MS. So that's in a calendar year, which is like about one new case of MS diagnosed per day in New Zealand. They found that it's 3 times more often occurring in women than in men. But they found something really striking as well, which was that it doesn't occur evenly throughout the country. And in fact, if one looks in the southern latitudes, in Otago and Southland, it's almost 4 times, 3.5 times more common than it is in the North Island. In Auckland, Waikato, and the central North Island, these rates are relatively low. There's still quite a lot of MS occurring, but not as common as one comes down to Wellington, Canterbury, and then in Otago, Southland. So that's a really striking observation. Something similar has been seen in Australia. Tasmania has a higher risk than in Queensland or New South Wales. And the question is, what accounts for this? Well, in New Zealand, we don't know. That's maybe a question that should be addressed in the future. But we have some clues from studies that have been done elsewhere of the risk factors for MS. So the first set of risk factors are genes, and with the modern genome screening, it's now apparent that there may be 150 or more genes that contribute to the risk for MS. They all have very small effects, but if you add them up, then they may be really quite an important factor. But they're not the only factor, and there are things to do with the environment that increase the risk, such as low vitamin D levels. And low vitamin D is more likely to occur in places where there's not much sunshine. So maybe that could be a factor in why MS is more common in the south of New Zealand. Epstein-Barr virus infection is important. If we did a blood test here tonight amongst us, probably amongst the general adult population, 80% of people have had this Epstein-Barr infection. It usually doesn't cause any symptoms, but in some people it can cause glandular fever. In people with MS, there's a 99% likelihood of having had this infection. Smoking's a risk factor. Smokers have a higher chance of MS and also worsens the course of MS. And obesity in adolescents seems to also be a risk factor. And in Sweden, where there's a very big MS registry, it's been found that if you look at combinations of these risks, it can really be quite high. So if people have particular genes that are linked to MS and they're smokers, and there was also Epstein-Barr or obesity in adolescents, the risk may go up something like 10 or 20-fold compared to the general population risk. So that's quite significant. Now, what is thought is happening with these risk factors is that they are affecting our immune system. Our immune system produces the white blood cells, the lymphocytes that we need to fight off infections. That's its normal healthy function. But in some circumstances, they get activated so that they damage parts of our own body. It's called autoimmune disease. And that's what happens in MS, that as a result of these and maybe other risk factors we don't know about, the immune system gets turned on a little bit. It's still healthy in fighting off infections, that's not a problem, but it gets turned on in the sense that there's some immune cells that actually cause these MS lesions. So I want to now move to the rest of the talk to discuss the progress that's been made in treating multiple sclerosis. And before I move on to the details of this, I need to just briefly summarise the main types of MS. This is important because treatments can apply differently according to the type of MS. So for 85% of people with MS, it starts with relapses and remissions. Relapses are episodes of symptoms such as loss of vision in one eye, if the lesion causes optic neuritis, or it might involve a loss of sensation in the legs or an effect on walking if it involves the spinal cord. And that relapse will usually last for a few weeks and then it will disappear. It's followed by a remission. That's called relapsing remitting MS, and that's the way it starts for 85% of people. And for some people it stays like that, and the relapses may be very infrequent and may have good recoveries, and some people can even go through a lifetime without serious problems. However, most people with relapsing-remitting MS eventually develop what we call secondary progression. It usually takes about 10 to 15 years to develop, and that is where the relapses sort of fade out, but instead there is just a gradual increase in disability, usually an increase in problems with balance or walking most commonly. That's called secondary progressive MS. And that eventually 2/3 of people with relapsing-remitting MS develop secondary progression. And then there's a third type, primary progressive MS, where there's never any relapse. It tends to come on in an older age group, more in the people in their 40s and 50s, and it's just slowly progressive from onset, usually affecting mobility and balance due to involvement of the spinal cord. So there are treatments that can help to reduce the symptoms of multiple sclerosis, and also there are important strategies to try and improve health and wellness. And these are helpful for all types of MS. Now, I'm not going to actually discuss these. There are many treatments and strategies to improve health, well-being, and manage symptoms. I'm not going to discuss these in this talk because I'm going to, they are very important, but I'm going to concentrate tonight on progress with disease-modifying treatments. So these are treatments that actually change the course of MS for the better. And in this situation, the current treatments that we have are only effective in relapsing-remitting MS. There's a lot of work on progressive MS and developing treatments, and I'll come to that. So I want to spend a couple of minutes talking about what causes relapses and remissions in a bit more detail. Remember that we've already talked about the demyelination. So relapses actually occur when there is a new inflammatory lesion that develops in the brain. And this is when these immune cells that have been activated, called T lymphocytes they're called, they get activated. Maybe it's just in our genes, it may be an infection, Epstein-Barr, it may be low vitamin D, it may be a combination of things. That just in a certain individual has the bad luck to trigger off some of these immune cells that are reactive to myelin, they're sensitive to myelin, and so when they get into the brain, they cross into the brain from the blood, they trigger inflammation, and they damage the myelin sheath. And we can see these new lesions using MRI, and there are two types of MRI scans shown here. On the left is what we call a T2 scan, which shows the MS lesions as high signal, these 4 white spots, 1, 2, 3, 4 white spots in the white matter of the brain. And 2 of these lesions on another type of scan show high signal, and that's where an injection of a contrast called gadolinium is given. And gadolinium normally does not get into the brain, but when you have a new lesion where these immune cells are whizzing across from the blood into the brain, the gadolinium gets in and it shows them up. So here are 2 new inflammatory active lesions. We know that's damaging myelin, and then there are some older lesions as well that leave their signal, but they've healed up and they're not causing inflammation. So that's what the scan shows, and these new lesions will be associated with relapses when they occur in a place such as the spinal cord or the optic nerves. But the good thing is that usually in the following a relapse there is a remission, and this is due to a number of things. First of all, the inflammation just stops after. It's like having a cold. You get a swollen, red, inflamed nose or cough, and then it gets better after a couple of weeks, and so the inflammation stops. And then the myelin can grow back. We call that remyelination. And also, even if the myelin doesn't grow back, the nerve fibers after a while learn to conduct signals again. They're not so efficient at it, they're not so good, but they develop an ability to conduct signals, and that can improve function. And the final thing that can happen that leads to remission is that there are other nerve cells and fibers that weren't affected by the attack that they can take over. This is part of the brain's ability to adapt and it has reserve to compensate. So those are the 4 ways of getting better. However, remission is not always complete, and the real problem is that sometimes the nerve fibers themselves, not just the myelin, but the nerve fibers themselves get damaged and die, and once the nerve fibers are gone, there's no way biologically known to regenerate them. So to show the whole sequence of events in relapsing-remitting MS, it starts off with this inflammation from immune cells in the blood, crossing into the brain, attacking the myelin, causing this demyelination. We can see that here. And then after the inflammation goes, one of 2 things that can happen. Remyelination occurs here, which can lead to a full recovery, or if there isn't remyelination, You have some nerve fibres that survive and conduct signals, and so there may be a partial recovery, but others that actually have died because of the inflammation, and because without myelin they don't survive very well. And when the nerve fibre dies, that'll leave a permanent disability. Now, remyelination, as I said, does occur spontaneously, but really only in the early stages of MS, in the first few years of relapsing remitting MS. And this is a slide that shows how you can get this myelin. It's illustrated here in green. It's actually no different really from the normal myelin, but here's an example of the way myelin can grow back. But it does seem to die out as a process after the first few years, probably because the immune attacks, after a while, there are no oligodendrocytes left to restore the myelin, and also they result in scarring, which interferes with the progress of remyelination. So what's very much needed is treatments that can actually promote remyelination, and that's an area of active research. There are drugs that work very well in the laboratory to promote remyelination, and there have been some early clinical trials where there are some promising results. As yet, there's not a proven treatment, certainly some promising treatments that may in the future be able to enhance remyelination. So then I'm going to move on and discuss the treatments that we have now available for relapsed remitting MS. And here they are. The ones in black are all available in New Zealand. Beta interferon and glatiramer acetate, which is also called Copaxone, have been available for over a decade. And just in the last couple of months, 2 new drugs have been added in New Zealand, natalizumab and fingolimod. They're probably better known by their trade names of Tysabri and Gilenya. Now you'll notice that these new treatments are really quite powerful at preventing relapses. Natalizumab reduces almost 2/3 of relapses. Fingolimod about a half, 50%. The older drugs, not quite as good, but for some people still they're very helpful, reducing the relapse rate by 30%. There are some drugs that are now available in the UK and Europe and North America, and so may, not yet in New Zealand, but may come available. This drug, alemtuzumab, is very powerful at preventing relapses. Another called dimethyl fumarate is an effective treatment. Also notice that some of these are oral preparations. The asterisk means it's a pill that can be taken, and that can be an attractive benefit. The earlier treatments had to be given by injection, and that has often been problematic. So you can see that there are a range of treatment options, and that with some drug or other, there is a good chance of getting good control of relapses. Now, how do they work? How do they prevent relapses? Well, basically, they all have some effect on those immune cells that are causing the relapse. So some of the drugs modulate the immune cells. The modulate is a nice, gentle word. It means that they encourage them to sort of settle down, calm down a bit, so that they don't become sensitive to the myelin, they don't cause the damage. And they tend to be milder treatments. They're not so strong, and they're not so effective, but they're also relatively safe treatments. Now, the next approach is much more aggressive. It's to eliminate the immune cells. People sometimes call it immunosuppression, and this drug, alemtuzumab, does that very effectively. It actually targets receptors on the lymphocytes that basically almost destroy them for a few months, and then they do recover gradually. But there's 2 other really rather novel approaches, and those are the 2 drugs that have just been approved in New Zealand in the last few months. I want to briefly mention those. One of them, Tysabri, stops the immune cells from getting into the brain. It's like it puts up a barrier called the blood-brain barrier, and the other one, fingolimod, traps the immune cells in other parts of the body, which is really these are quite unique. So this is natalizumab, and the purple circles are the activated T lymphocytes. They're in the bloodstream. They've been activated by whatever it is that sets MS going, and they're all ready to cross the barrier, the blood-brain barrier. These are the capillary linings, and get into the brain. And they would, in the normal event in MS, get into the brain and cause damage. But this drug, natalizumab, latches onto them. It's an antibody that latches onto the T cells and stops them from binding to the capillary lining. They can only get, the T cells can only get across by binding to the capillaries and then jumping across. And natalizumab is very effective at doing that and very effective at preventing relapses. And fingolimod is also quite unique, and so these are models of lymph nodes. So we've got lymph nodes all around our body, and our T cells, T lymphocytes, are constantly circulating through the body, through the blood system, through the lymph system. They're going in and out of lymph nodes, and this drug, fingolimod, basically blocks them in the lymph nodes. They come in, and there's a signal from the drug that sequesters them there, and they don't get out. And so the result is they're tucked away, and if they're not getting it back out in the blood, they're not getting into the brain. So that's natalizumab and fingolimod. So you might say, however, because often these most powerful treatments, like Tazabri, are not the treatments that are given first to people with MS, or have not been historically. And you might say, well, why not give the most powerful treatment? That would seem sensible. Well, unfortunately, there's a general rule, which is the greater the benefit, the greater the adverse effects. And in the case of natalizumab, there's a condition called PML, which is a PML is due to a viral infection. It's a very common virus that about half of us have got in our system. It's normally completely harmless, but under certain immune compromised circumstances, and having natalizumab is one of those, it can develop, and it's a terrible, rapidly progressive and quite often fatal brain infection. It occurs in about 1 person in 150 who have natalizumab. There is a way for screening to show that you have a very low risk, and so that can help to decide whether this is an okay treatment to take. The other reason is that, in fact, some people's MS is mild. They may actually not need any treatment, or they may find that beta interferon is, for example, quite sufficient for preventing relapses. Now, there's some big unanswered questions in treating relapsing remitting MS, and one of those is how quickly should the treatment start? So should it start as soon as MS is diagnosed? Someone's still perfectly well, they've had a complete remission for their first or second episode, should you start then, or should you wait maybe for a year or two, wait and see whether there are going to be more problems? There isn't a right and wrong answer to this, but I would say the move is towards early treatment, because the feeling is that the earlier that you get in, the better the chances of long-term benefit. And we know that if you do scans on people, even if they're not having relapses, they are having new gadolinium-enhancing lesions, and so there is new damage occurring. And so the earlier one starts treatment, the greater the potential to prevent problems downstream. But it remains to be proven. And then there's another big question is, do treatments have long-term benefits? Do they stop people getting secondary progressive MS, for example? We don't yet know, because it takes years and years to find out, and the controlled clinical trials that we do to look at these treatments only last about 2 or 3 years. But there is a little bit of evidence that there are long-term benefits, and this slide shows one line of evidence, which is in the UK. We've had beta interferon and glutamastate since 2002, widely used on the National Health Service in what's called the risk-sharing scheme. And this is because it was felt that these drugs were too costly to be cost-effective, and so they could only be given in a scheme where people were monitored continuously over 10 years, and that the drug costs were altered to ensure that they were being cost-effective. So there are basically 4,000 UK patients who have been followed for up to 10 years. Currently, what's been published is the 6-year follow-up, and that, to try and see whether the drugs were helping, then there's a matter of having to find a comparison group who didn't have any treatment. And for this study, they went to Canada, to British Columbia, where there's been a detailed registry of following people with MS in Vancouver and in the province of British Columbia, going right back to the 1980s, when there was no treatment. And so they took the data on untreated Canadian patients during a period prior to the drugs becoming available. And the comparison showed that the UK patients In both groups, there were some people who got more disability, naturally, but there was a 35% less increase in disability in the UK treated patients. And it suggested these drugs are cost effective and that there is a long-term benefit. Now, this is still only 6 years in the life of MS. That's still relatively small, but it's certainly encouraging that, you know, there are long-term gains. So the final part of my talk is going to be on progressive multiple sclerosis. Now, I mentioned that at present, unlike relapsing-remitting MS, there isn't yet a proven treatment to slow or stop progressive MS. So to try and tackle the problem, the first thing is, why does it develop? What's actually underlying progressive MS? And what's emerged from a lot now of post-mortem pathology studies is that it's a different type of pathology, and that the inflammation, the immune cell mediated inflammation that we saw in relapsing-remitting MS seems to all disappear and fade out. But instead, there's a rather widespread loss of the nerve cells and fibres. And this can be in the spinal cord as well as the brain, and naturally in the spinal cord this is more likely to cause problems with mobility and limb control and so on. Now these pictures are showing the nerve fibres as tiny black dots in cross-section. So it's a special stain for nerve fibres, and you can see on the left is a healthy individual. You can see lots of high density of nerve fibres on the right, a person with MS, and you can see how the number of nerve fibres is significantly less. So this is what's going on in progressive MS. So in trying to tackle it, we need to understand what's causing this loss of the nerve fibres. Well, there are several things that seem to play a part, and it's still this is like a jigsaw puzzle that's half completed. But there is some inflammation, but it's not the type that comes from the immune cells. It's something within the brain itself, just a low-grade inflammation. There are cells in the brain, such called microglia, which can just get stirred up and activated and act as local inflammatory cells, and they seem to be playing a part. There's a problem with energy failure. So after a period of time, maybe with repeated attacks, as time goes by, the nerve cells find it harder to survive because their energy systems are being depleted by the damage that's occurred. And there are cell energy producing components in the cell called mitochondria, and there's a lot of research going on to understand how they function and trying to find ways of improving mitochondrial function and aiding the cells to survive. Lack of remyelination is almost certainly an important thing, because if the nerve fibre has its myelin sheath protecting it, it's much less likely to degenerate. And the final thing is there's just something about getting older, that it seems as though aging per se is a risk factor for progression, and indeed the studies that have been done in New Zealand, and Sri Dayal is busy writing up some of these studies at present, have shown that as people get older, the age itself is quite a risk factor for the development of disability. And there's also been, in the last few years, quite a lot of associations noticed with vascular, the sort of risk factors of vascular disease as people get older, such as obesity, hypertension, high cholesterol, sort of things that, common problems in our society, but they also seem to be associated in some way with MS and with its progression. And there may be some avenues for treatment and wellness and general health that will benefit progressive MS in that regard. So what's clear anyway, there needs to be treatments that protect the nerve fibres, that help them to survive. And the other thing that's needed is to do efficient trials. So to try and prove you've got a treatment to stop progressive MS, you would need to have what's called a double-blind placebo-controlled trial, where half the people have the active drug, half have a placebo, and then you follow people up long enough to show that you can slow the progression of disability. Now, disability only changes quite slowly in progressive MS, and so this usually means a very big trial, maybe of 1,000 people for 3 years, and that's very expensive. So there need to be other ways of measuring the progression. And this is where MRI scanning plays a part, and this is some of the research we're actually involved in London, is to measure on the MRI scan the change in the amount of brain tissue. Because in MS there's an accelerated loss of brain tissue. We're all losing a bit of brain tissue, I'm afraid. It's only about 0.2% per year, but that's just normal. We're all losing some. But in MS, it's about 5 times that. And so the MRI scan can measure this change quite precisely within a year. And the little blue areas on the scan at the bottom show the areas where there's been loss of tissue over the course of the year. So we think this is a sensitive way of monitoring the process, and importantly then seeing whether there are treatments that can slow that brain atrophy. And this could make for a much cheaper trial. And to illustrate that, I want to show an example of a trial that was done in the UK, funded by the Medical Research Council, a trial that started about 8 years ago. Very big study because it was based on evidence that cannabis drugs, or cannabinoid drugs, can actually protect nerve fibres. In experimental models, there was quite good evidence. And this large trial compared cannabis with placebo, and as you can see on the left, unfortunately the disability progression was identical. 60% of both placebo and cannabis treated people had progressed over 3 years. But to show that effect on disability, or that lack of effect, cost a £5 million trial. Had we only just used MRI to show whether it was protecting against brain atrophy, which it didn't do, but had it, we would have only needed to do a trial of 1/5 the size. It would cost $1 million. So that's the way things are going, smaller trials using the MRI to try and see whether we have a neuroprotective treatment. And there's been a positive trial with just that approach, which is my colleague, Dr. Jeremy Chataway, in London, conducted this trial of simvastatin. So simvastatin is one of the statin drugs that's used to treat high cholesterol, and people either had a placebo or a very high dose of simvastatin, and over 2 years there was 40% less brain atrophy in people with, so for secondary progressive MS, 40% less brain atrophy in the simvastatin arm. So that was very encouraging. And now with that positive trial, Jeremy is going on and trying to do a bigger trial to hopefully show that it does slow the progression of disability. He's also busy with another trial that's just underway, which is testing 3 more drugs, again looking at the MRI as the outcome measure. 3 more drugs which in early clinical and experimental studies are all quite promising, we hope might slow the progression of MS. So a lot's going on to try and tackle progressive MS, and I want to mention particularly a thing called the International Progressive MS Alliance. This is a multinational initiative which aims to fund large-scale research towards developing an effective treatment. It started about 2 years ago. I believe it's raised already about $20 million. It's the result, the funding is the result of multiple national MS societies coming together, Spanish, UK, German, Italian, Canadian, Australian, United States, and several other MS societies coming together to find the funding. And the idea is to bring together investigators from multiple centres working in big groups, collaborative groups, to try and really tackle the problems of MS, of progressive MS, to try and understand those mechanisms, develop treatment strategies that tackle the mechanisms, and then develop trials and results that will hopefully deliver effective treatments for progressive MS before very long. So to summarise, there has been a lot of progress in understanding MS in the last 20, 30 years, even in the last 5 years. I would say accelerating understanding, and that of course leads to new treatment strategies. The more you can understand the basic mechanisms, the better the more rational the treatment strategies, the better the chance of success. there has been a lot of success in relapsing remitting MS and an increasing range of treatments, and now we're in a phase where treatments are being actively sought to try and stop progressive MS, and also to try and enable that remyelination that hopefully will help to prevent progression occurring. So I think it's a positive time. There's been a lot done, and I think there should be a lot more progress in the years to come. Thank you. Yeah. So I think that there are a number of vitamin associations that have come and sometimes gone because the further investigation hasn't shown any clear association. One example is vitamin B12, which a deficiency of vitamin B12 actually causes something that looks a bit like MS, but it is definitely a different condition. That's very clearly proved. And I think at the moment vitamin B6 is something where there are some ideas about it, but that actually if you were to test me with MS, they would not be deficient in vitamin B6. So I think it's an area that is, vitamin D is another area where there's quite a lot of evidence that low vitamin D levels are associated with an increased risk of MS and also with a worse course of MS, and that suggests that treatment with vitamin D might be beneficial, and a lot of people take vitamin D and it's perfectly reasonable to do so. There is a trial underway to try and get direct evidence of whether vitamin D is effective, and that trial is being done here in Australia and New Zealand. People with the first attack of suspected MS, what's called a clinically isolated syndrome, are being offered a year of treatment with vitamin D or placebo to try and see whether it definitely makes a difference. So I think in vitamin B6 it's still, as far as I'm aware, still quite an early stage. I'm not aware of a controlled clinical trial, a blinded controlled clinical trial being underway or having been completed, and that is regarded as the gold standard for proving that a treatment works. And it is quite important to do those controlled trials, saying MS is a very variable condition, and we can have spontaneous improvements, relapses and remissions that we talked about, and therefore to be absolutely sure about a treatment benefit, one does need to do these controlled trials. So I have personally, but of course there have been quite a few, several trials of Vampira. So this is a drug that improves the conduction of signals in those nerve fibers that have lost their myelin. It changes the flow of currents in and out of the nerve and improves the signal conduction. And there have been studies that show that some people experience an improvement in muscle strength and in mobility. And it is used to some extent where I work. It is used. There are criteria for eligibility according to the type of problem of mobility. So it's quite a novel treatment approach, and certainly for some people it is helpful. It depends on what is causing the muscle weakness. If the muscle weakness is heavily due to this problem of the demyelinated nerve fibers with the conduction block from demyelination, then this may be a promising treatment. Sometimes it's due to actually a loss of the nerve fiber itself, and then it won't be an effective treatment. So it does depend on what the situation is.
About vibration therapy for relief for immune symptoms?
Right. So I think that I think probably what we're talking about there, you're talking about relief of any particular symptoms, pain, or... I'm not familiar with that exactly, but there is, for example, a form, sometimes painful symptoms can be helped by sensory stimulation, other forms of sensory stimulation that can modulate the pain. Acupuncture, for example, or transcutaneous electrical stimulation. So I could see a way in which some sort of sensory stimulation of that type could be helpful in, relieving some unpleasant symptoms, particularly painful symptoms.